Hello everyone, this week we're going to be covering neurocognitive disorders. Neurocognitive disorders are disorders in which impaired cognition has not been present since birth or very early in life, thus represents a decline from previous levels of functioning. These disorders can be further explained as clinical deficit in cognitive functioning that are acquired and not developed. Delirium is a disturbance in attention and cognition. Other specified delirium, individuals present with symptoms and characteristics of delirium but do not meet full criteria. This diagnosis is used when the clinician chooses to communicate the specific reason that the presentation does not meet the criteria for delirium or other neurocognitive disorder. Specific delirium, individuals present with characteristics of delirium that causes distress or impairment but do not meet full criteria for delirium or any other neurocognitive diagnostic class. This is used when the clinician chooses not to specify the reason that the criteria are not met. Major neurocognitive disorders, evidence of a significant cognitive decline from previous level of performance in one or more of the various cognitive domains, complex attention, executive functioning, learning and memory, language, perceptual, motor, or social cognition. Mild neurocognitive disorders are evidence of a moderate cognitive decline from the individual's previous level of performance in the same domains as the major cognitive disorder. There are three main syndromes of neurocognitive disorders: delirium, major neurocognitive disorder, and mild neurocognitive disorder. And delirium can be thought of as a behavioral manifestation of an underlying metabolic disturbance that impairs central nervous system functioning to the extent that individuals show reductions in their basic ability to attend to the environment. These individuals will show impairment in at least one of their cognitive ability, such as memory or language. Delirium differs from major and mild neurocognitive disorders in that it develops rapidly in hours or days and can be linked to medical conditions, substance intoxication or withdrawal, or other causes. Delirium is also unique in that it can completely resolve if the underlying cause is treated. Once it is established that a person has a major or mild neurocognitive disorder, the next step for the clinician is to determine the most likely etiologies. The etiology can be determined because of a combination of symptom, time course, cognitive domains involved, associated medical neurological condition. In some cases, a diagnosis of major or mild neurocognitive disorder depends on the presence of a known medical condition causing cognitive decline, as with following etiologies: vascular disease, TBI, substance abuse, medication use, HIV infection, prion disease, Parkinson's disease, and Huntington's disease. For other neurodegenerative etiologies, including Alzheimer's disease, frontotemporal lobar degeneration, and Lewy body disease, major or mild neurocognitive disorders are primarily diagnosed based on presence of cognitive, behavioral, and functional symptoms. So what makes neurocognitive disorders unique? Neurocognitive disorders are unique because the underlying pathology etiology can be potentially determined due to extensive research, clinical experience, and expert consensus on the various diagnostic criteria. These various diagnoses have been closely developed through close consultation with expert groups for each of the disease entities and align as closely as possible with the criteria for each of them. The neurocognitive disorders involve a decline in cognitive functioning from a previous state, as evidenced by concerns from the individual, an informant, or the clinician, and objective test performance. This evaluation differs from that for intellectual disabilities, in that intellectual disabilities involve a baseline impaired level of cognitive functioning. There are 6 neurocognitive domains, which consist of complex attention or sustained attention, divided attention, selective attention, processing speed. So this symptom includes individuals having difficulty in environments with multiple stimuli and are easily distracted. Executive function or planning, decision-making, working memory, responding or feedback, error, correction or overriding habits, inhibition, and mental flexibility. So these individuals struggle with abandoning complex projects. Learning and memory or immediate memory and recent memory. Individuals require frequent reminders to complete tasks. Language or their expressive language. Individuals frequently use general phrases such as "you know what I mean" or "that thing over there," and the individual struggles with recall of friends' names. Perceptual motor includes abilities subsumed under terms visual perception and perceptual motor, and these look like having significant challenges with previously familiar activities like cooking or cleaning. Social cognition. Individual behaviors are clearly out of acceptable social range, such as insensitivity to social standards of modesty and topics of conversation. So what role do social workers have in addressing neurocognitive disorders? So while psychotherapy has been found to not be effective with individuals with dementia, treatment should be focused on social and environmental interventions to protect the safety of the individual and the people around them. Social workers can also work with families and help set goals that are reasonable for the individual and their functioning. In the encounter with the patient, the clinician must take care to express empathy related to this dramatic change in life circumstances, increase insight, and make appropriate referrals as needed. Learning points from the article. It is important to treat other modifiable contributors such as pain, constipation, and defecation and medications. It's also important that the treatment of these various contributors continue to be treated even if medication for behavioral and psychological symptoms of dementia are warranted. Non-pharmacological methods are the first recommendation when treating disruptive behaviors that are associated with dementia. However, if the behaviors are dangerous or cause distress to the individual, psychotropic medications may be warranted. Antipsychotics are the most prescribed medication for the treatment of dementia despite their risks. They are the most studied medication for the treatment of dementia and have the most efficiency. These medications are used to target symptoms of agitation, aggression, and psychosis and should only be used if the symptoms become dangerous or distressing to the individual. Benzodiazepines and mood stabilizers cannot be recommended for treatment of psychological and behavioral symptoms because of data and research that found that these medications cause an increased risk of adverse effects and low probability of being effective. Cognitive enhancers are primarily used to help slow down cognitive decline in individuals with dementia. Cholinesterase inhibitors are recommended for neurocognitive disorders due to Parkinson's disease, Lewy body disease, and Alzheimer's disease. Memantine is only used for moderate to severe Alzheimer's disease. Selective serotonin reuptake inhibitors, so SSRIs, have also been studied for treatment for these disorders and have been found to be more effective than the placebo or just as effective as antipsychotics for agitation and irritability. There are other medications that have limited evidence for treatment, such as trazodone, carbamazepine, and valproate, have been found to be more effective than the placebo, but they still have limited research and data.